Okay, so we're gonna talk about sexual health assessment. So when I say sexual health assessment, what do you guys start to think of? Where does your mind go on what your responsibility is going to be as far as being the nurse providing care for a patient getting a sexual health assessment?
Like their sexual history,
Sexual history, absolutely.
their partners.
They're sexual partners. Um, Asking questions about sexual health. Somebody said education for sure. So if they have any concerns, sure. History of STI, yeah, I think that'd be really important to include what their base knowledge is. I like that, Hannah. Will you elaborate a little bit on when you say base knowledge?
I guess I just mean, what do they know about their own bodies? What do they know about safe sex practices? What do they know about just what is their general level of knowledge regarding this system?
That is very good. That's a really good answer. What kind of symptoms are they having? I see that, Brooke. So I think that kind of goes along with that too. Questions or concerns about sexual health. People automatically assume that when they grow up, their parents or someone close to them will talk to them about sex. And that's not always true, right? Anybody have that experience where your parents just didn't talk to you about sex? You didn't know anything. And then everything's new and different and you don't know. And you go to the doctor and they're asking questions and you're like, I don't know. So that's kind of what we're going to be talking about, but we're not just talking about sexual health of adults. We're also going to talk about how do we incorporate a sexual health / reproductive system assessment when we're talking about kids and older adults too, because it's going to be across that lifespan from birth through childhood, adolescence, adulthood, pregnancy, into older adults. And there are a lot of changes with each of those systems and a lot of different approaches. And so that's kind of what we're going to focus on this first part of the morning, is just to kind of figure out how do we go about doing that. Is this a conversation that's easy for you guys to have? Is just talk about this with your patients of any age, gender, sexual orientation?
Well, even now, Shanessa, we have to ask them first, how do they identify themselves as, right? We can't just
Exactly.
assume they're female or male. Like,
Right.
I've seen that in the paperwork, like when I've taken my kids to the doctor now.
Mm-hmm. Yep. There's not just female or male. You have to ask them how they identify for sure. And that will change how you're approaching your sexual health assessment too, won't it, Liz?
Yes.
It will. So I think the first thing we're going to start out with doing is I have some review NCLEX style questions to kind of go over and just test your knowledge base and see where you guys are at. And then we'll kind of walk through these questions. They're not hard. You might know some of them, you might not know some of them. And then we'll go from there to kind of get the feel of a sexual health assessment, taking a sexual history. And then we'll talk about some sexual dysfunction and concerns. Okay. So when we are talking about assessment of the reproductive system, okay, you guys hit it on the head talking about concerns with reproductive issues. Typically, this is going to link back to a person's sexuality or concerns about their sexual functioning or dysfunction. Even being a nurse for several years, the moment in time I remember this the most strongly was when I was a fairly new nurse. I was probably 23, 24. And there was a college student sitting in my ER who was home for the weekend and he wasn't feeling very good. And he was having lower abdominal pain and some fever. And that was it. He didn't have any other symptoms. And it ended up that he had an STI. And so working through that with someone close in age to me who I knew from my town, telling them, hey, we're gonna need to test you for STIs. Is there any possible way this could be a thing for you? And really trying to figure out how to have that conversation was probably the hardest part of nursing sometimes, is figuring out how do I talk to my patients about this when I know them, they're close in age to me. This is really super embarrassing for them and for me because I know them and I know their family and their parents and their moms in the room. or because sometimes we're not comfortable with our own sexuality. Maybe it's because we're not comfortable discussing another person's sexual practices. And so this is something that people, healthcare providers included, doctors, make a lot of assumptions about for people. Is this is, oh, it's fine, it's just they're old, we don't need to talk about their sexual health and sexual functioning. And so this gets missed. So one thing I really encourage you guys to do, as we're kind of talking about this, figure out how you would plan this conversation with different types of patients in your head, so that this isn't a topic of education that gets missed in your nursing care, because it really does get missed for a lot of people. Okay. Assessment of male and female genitalia should be part of every complete physical assessment. I'm not saying you need to have them lay down in the lithotomy position and spread everything out for you and touch everything every time, but discussion at least of this, and if there is any type of problem, knowing the next steps to take to perform that physical part of this assessment, very important. Lou said being sensitive to gender identity, sexual orientation, sexual practices, and age and understanding, because some of our language that we're going to use probably isn't appropriate to discuss with an 8-year-old or with a developmentally delayed individual. So just keeping that in mind. All right, so here's your first question. I want you guys to think about this. Okay, so if you know the answer, the external male genital structures include which part? Which one of these, the testes, scrotum, epididymis, or the vas deferens? Which one of these is the external part of the male genitals?
Scrotum.
Scrotum, okay. Scrotum, it's kind of our answer of choice. Okay, good. It is the scrotum. So why would we eliminate the testes? Why are we eliminating the first answer? Let's talk this through as we're going through NCLEX style questions.
Because they're inside the sac, aren't they?
They are inside the sac. Yep, they're absolutely internal. Okay, good. So those are inside. How about the epididymis?
I don't know what that is. Teach me.
Breeden says it's also inside. It's on top of the testes. He's correct.
Thank you, Breeden.
What'd you say?
I said, thank you, Breeden.
Yes. Thank you, Breeden. Okay. Also internal. I'm actually going to write that on top of testes. How about the vas deferens? It's internal. Do you know where it is? Inside. We knew the epididymis was on top of the testes. The testes are inside the scrotum, or inside that scrotal sac. Internal behind the bladder, pretty close. Yeah, it's like the so the urethra goes from the bladder through the penis to the end, and the vas deferens goes from like the seminal vesicles out that way. Yep, tube that connects the testes to the seminal vesicle. Perfect. So also know it's inside. I'm just gonna say connects lots of things. So I know it's a simple question. You guys knew that answer right off the bat, but as you're practicing answering your questions, it can be really helpful to go through, even if you know what the answer is, why do you know what those incorrect answers, why are they not correct? That can really help you prepare for your exams and everything like that. So let's do a few more just to kind of see where we continue to be at. All right, so when performing a genital examination on a 25-year-old man, the nurse notices a deeply pigmented, wrinkled scrotal skin, with large sebaceous follicles. On the basis of this information, the nurse is going to do what? What do you think?
C.
You said B?
C.
D?
C.
C. C. You said C. C. Got it. Okay. Anybody else want to comment on this?
I mean, I think D would also be good because you would want to know their history, maybe. But I think C would be first, but I could see where G is also important.
Mhm.
I agree with Luz. I think it's either C or D.
Okay,
It's not normal, I don't think.
And he may have, just by noticing that first abnormality, you might run up on other abnormalities, maybe.
Mhm. You might. Okay, so don't shoot the messenger, okay? According to your textbook, they actually would consider the correct answer to be B. Consider the finding as normal and proceed with the examination. Now, do you have more to say and discuss this? What do you
Well,
think?
I mean,
Oops,
I guess
sorry.
we could ask the patient if that's normal, maybe if he was born with it, but wouldn't you assess it I guess by asking, well, should you consider it normal? What if it's like a genital wart?
Okay, but it's just sebaceous follicles, so it's just gonna be
Yeah.
the location, because Breeden's right, the scrotum is normally wrinkled, and was talking about deeply pigmented, it's talking about the skin, so don't have a scrotal sac myself, but usually they are kind of darker in color than the skin around them. Is that correct? People with testicles? They don't want to answer. I don't blame them.
So, we got 3 in here.
Sounds about right. Yeah. So those first two things are right. And with the sebaceous follicles, that doesn't mean there's actually bumps on there. It could just be those surfaces in the skin like we have on our skin on the surface of our arms. We have sebaceous follicles on there, and that doesn't bother us. We don't think that's abnormal. Does that make sense? But you guys are right. If we were in doubt and we were concerned that there was something wrong, we would absolutely obtain a more detailed history, and we would assess the testicles for presence of masses or painless lumps. Okay. And then if we really needed to, we'd squeeze the glands and check for presence of discharge and all that. So yes, that makes sense when knowing what sebaceous follicles is. Okay. All right, so that question was a little bit harder. We're gonna move on to the next one. The next one's easier again. A male patient with possible fertility problems asks the nurse where sperm is produced. The nurse knows that sperm production occurs in the where.
C.
You are correct. Good work. We know it's not the vas deferens. Why we know it's not that?
It's the tube that connects it all.
That's the tube that connects it all, right? Doesn't actually make anything. Okay. We know it's not the prostate. Why is that?
Isn't it a
Sphincter.
gland?
It's a gland. Yep, it's a gland. It's a sphincter, right? Okay. Testes. The epididymis, we said, sits right on top of the testes. Okay. Prostate's more for hormones. Yep, good. Breeden, I saw you had a question earlier saying nurses do that. You've only ever had a doctor do that. If we had to check for discharge as a nurse, I don't know that I would feel confident to go ahead and do that collection. I'd prefer a provider would do that as well. So that's a good question. Just thought I'd throw that out there. I saw it in the chat, wanted to answer it. Okay, next question. The mother of a 10-year-old boy asks the nurse to discuss the recognition of puberty. Which reply by the nurse is correct?
D?
D?
The answer, according to the book, is actually B. The first sign of puberty is enlargement of the testes. But I would probably agree with you that are saying D, because I think it's going to depend on the boy, whether or not they get pubic hair first or they start to have testicular enlargement first. Why is answer A not correct?
Because
It's
it starts from
young
11 to 14 or 12 to 14.
Because puberty is different for everybody.
Puberty is different for everybody. Yep, that's exactly the right answer. So yeah, maybe 12 to 14 is most common, but puberty is different for everybody. Okay. And why is C not correct?
That's too late.
Yeah, that is too late. If it doesn't start growing till 16, probably we're having some concerns because there's different stages that they'll hit at different ages. Because puberty usually starts earlier. Yep. So when we have an answer like this, where the correct answer from the book says the first sign of puberty is enlargement of the testes, and then you have the one about the development of pubic hair, how are we going to know which one's correct? How are we going to rationalize that out? Excuse me.
Well, I don't know, because you say you agree with us, but the book says something else.
Right.
I guess it'd be up to your discretion.
It's up to me to change the answer correct for you. Is that what you just said?
Sure.
Yeah. Okay. I think what you'll find is most commonly the first sign of puberty is going to be enlargement of the testes before the pubic hair starts to grow. So,
Wouldn't that kind of go along with like women develop like their breast buds before, they start getting the pubic hair? So wouldn't it be like close to the same thing?
it's kind of like that. Yeah. And we'll talk about that a little bit more when we get to that sexual functioning lecture, because we're going to talk more about the stages of puberty in that one. All right. An older man's concerned about his sexual performance. The nurse knows that in the absence of disease, a withdrawal from sexual activity later in life may be because of what? This one's an easy one. You should all get this one right because we talked about it in farm.
Side effects of medication?
Side effects of medications. Absolutely. Okay. So why is answer B not correct?
Man's libido doesn't decrease, right? Women's does.
It can decrease. But is that usually how am I going to phrase this?
Just because the activity stopped doesn't mean that his performance isn't good, right?
Right. Just because the activity stop doesn't mean his performance isn't good. Okay. That's a good way to put that. I was also thinking that if typically men do, that's what they always tell us, right? Men versus women. Men think about sex a lot more. They want more sex. They have a higher libido. If their libido is decreasing, there's probably something underlying going on than just not wanting to have sex. Make sense? Kind of follow? The side effects of medication will for sure do it. Okay. Do they have decreased sperm production later in
Yeah.
life? What?
I don't know. Marisol says yes, I say no. I don't know.
They do have decreased sperm production, but would that contribute to them withdrawing from sexual activity?
No.
No,
No.
because it's someone getting a vasectomy. They still don't.
Yeah,
they,
they
they
still,
don't have
they
sperm.
still
but
do it.
Exactly. Okay. Yes, Breeden, if testosterone decreases, they would have a change in their sex drive. Okay. But they're not going to have a decreased libido just from aging. If there's a decreased libido, there's something else underlying it, is what we're getting at. So the answer says decreased libido with aging. The aging is not going to cause the libido to drop necessarily just because they're getting old. Decreased pleasure from sexual intercourse, does that contribute to withdrawal of sexual activity? Do they have
say
decreased
could.
pleasure?
I
What?
say it can because they maybe the positioning may not be as comfortable.
Okay. So they might have some decreased pleasure from sexual intercourse, you think?
And then since they're dry, I mean, well, they're older, they might be more susceptible to being drier and
Okay.
it can be uncomfortable.
Okay. Sure. Okay. But more than likely they will still have pleasure. So I don't think they're worried about not having pleasure. If they're having sex, they'll still have some level of pleasure. That's not going to lead to a decreased activity in sexual or decreased level of sexual activity. What's going to do it, I think, Breeze, who said that? About the
Yeah, it was me.
physical changes. I think it'd be from the physical changes that they wouldn't have as much sexual activity, but it wouldn't necessarily change the desire, because if they can make it happen, they'll still achieve, the goal is still to achieve pleasure. Okay. The best answer here, I know some of them, again, this is why these questions are so hard. The best answer is going to be side effects of medication, because that's going to be the thing for sure that's going to cause changes in sexual activity, because older adults typically have more health problems. Okay. If he's concerned about his sexual performance, it's not because he has decreased libido and it's not because he's having decreased pleasure. Something else is going on that's causing him to be unable to perform the way he was before. Following? Yes, no, we need to talk about this some more.
We're good.
Good. Okay, good. So smart, guys. So smart. Okay. When the nurse is conducting a sexual health history from a male adolescent, which statement would be most appropriate to use at the beginning of the interview?
D.
D is correct. This one's all about therapeutic communication. Okay. Why would answer A not be appropriate to start your conversation with?
Because they're probably, you don't know if they're always having sex.
Right. We don't know if they're having sex. We need to determine that first. Okay. There's no report, right? Yeah, we don't have a trust with them. We can't just blurt out, you use condoms. Okay. A is making an assumption. Absolutely. Okay. What about B? How do you think about that? You don't masturbate, do you?
I You feel don't like want to belittle them.
Yeah.
That's too intrusive. Maybe they're not comfortable answering that question.
Probably offensive, too intrusive, judgmental, not comfortable. Okay. How would we phrase that? Because once we set up that rapport with them, we ask them, do you have any questions about sexual activity? Okay. We've started with that. Now we're going to go through some things. Okay. Now let's talk about this. Are you sexually active? That'd probably be the first question I would ask. What about you? Think so?
Yeah.
Because then you
Yeah.
could dive deeper into the conversation.
Right. Okay. What do you consider to be
And you could
sexually
ask them
active?
about it.
Okay. And we can ask them about masturbation, but I don't want to say you don't masturbate, do you? I would ask them, do you masturbate? How often? Right? That would be more what we would need to discuss. Have
How
you
about
had
do you
sex in the
pleasure
last
yourself?
6 months? is an appropriate question, but not how I'm going to start my conversation, because this teenage boy doesn't know me and now I'm asking him if he's having sex. And you don't masturbate, do you? Right? I've made him very uncomfortable. He's not going to want to talk to me. He's going to lie. No. No. Right? Agree, disagree?
Agree.
Agree. Great. See, so smart. All right. During a health history, a patient tells the nurse that he has trouble in starting his urine stream. This problem is known as
D. Hesitancy.
hesitancy. It is D. Okay. Why is it not urgency? What's urgency?
When you frequently have to go.
When you frequently have to go, right? Yep, the need to go right now, that pressure. Okay. Dribbling.
Incontinence.
Incontinence, right? Or after they're done urinating, they leak in different places. Okay. Frequency.
Too often.
Yeah, often, all the time. It's kind of like urgency a little bit, except it's not so much pressure, it's more the amount of times that they're going. Okay. Then you have hesitancy, that trouble starting the stream. And with that, you'll probably find they'll also have trouble continuing the stream throughout. So they'll have a hard time starting it and then keeping it going steady until they're finished. Okay. During the interview, a patient reveals she has some vaginal discharge. She's worried that it may be a sexually transmitted infection. The nurse's most appropriate response to this is what?
I would say C.
C. Good. Why do you say C?
Just
Because you're,
listen.
you're observing the color of the discharge. And it could tell you more about a specific type of STI without having to screen yet.
Right. And like Breeden said, not all discharge is related to sexual intercourse or sexually transmitted infections. So maybe it's something else altogether. So finding out what color it is would let us know if we're on the right track or if we need to do some different questions, right? Okay. So why would we not use the phrase, oh, don't worry, some cyclic vaginal discharge is normal?
That's very dismissal. Like you're not concerned about it.
Very dismissive, not concerned about it, totally just writing off her concerns. Absolutely. Okay. Have you been engaging in unprotected sexual intercourse?
That would be more of a follow-up question after you get more information of the discharge. And
I agree, Marisol. That would be a follow-up question after we get more information about the discharge. Have you had any urinary incontinence associated with the discharge?
That would be also like a follow-up.
Also a follow-up, for sure. I'd like some more information about the discharge. What color is it? That's a great way to go, because when we don't know something, we got to ask more questions and set that up. We can't just make assumptions. You guys are doing really good. Okay. When the nurse is interviewing a pre-adolescent girl, which opening question would be least threatening?
A.
I would say D.
I would say C.
Okay. Okay. Those who say A, why would you say A?
Because I'm sure she does have I'm sure she has a lot of questions, but by you
Mhm.
asking, do you have any questions? She can start off with yes and ask you what she's questioning the most, maybe.
Mhm.
I don't think it would be D, well, it could be, but it's more focusing on yourself versus the patient.
Right.
I think it would be D because you're getting on a more personal level with them. You're relating to them and you're still interacting with them and letting them know how you would feel if they were in your position.
Okay.
But also they could not be scared, but you could scare them by saying D, I believe. I don't know.
What if she isn't scared and you're saying that you're scared worries her? Good point. Very good point. Okay. All right. So this is a really good question because it is challenging. Okay. So you all are in total agreement that it is not B. What has your mother told you about growing up? Okay.
Because mothers don't say anything.
Not everybody's mother tells them things. Not everybody has a mother around to talk to them either.
Well,
Okay.
And like I told Luz earlier, I feel like the Hispanic culture, like we just avoid that topic.
You just
Like,
avoid
we
that
don't-
topic.
Yeah.
Okay.
It starts when the girls are pregnant. Oh, you're pregnant.
Exactly when it starts.
Okay. So we talked about A and D. Those of you that said C, why do you think C? Why would you start with that?
I feel like it's the least intrusive question that you could ask.
The least intrusive question you could ask.
I feel like it's not too broad.
Yeah, not too broad. Could give you a time frame. Sure. So
But
there's
also
main-
maybe when they're like pre-adolescents, maybe they really haven't even noticed their body changing, you know?
Mhm.
So I don't know.
Okay.
Maybe they haven't even noticed that their body has been changing.
Maybe they haven't, but they likely have. Then you can discuss the changes if there's any at all. Sure. They might not have any questions about growing up either because they might not, like you said, they might not have noticed any changes, but they also, maybe they have noticed some changes and they're embarrassed to ask those questions. So this C is the correct answer because I think it's going to give us a more focused, specific look at what we're trying to assess. Because we want to assess a couple of things because we're looking at how much knowledge do they have about what's happening? How much awareness do they have of their own bodies? And then we can evaluate any concerns or questions that come from that. So it kind of gives us a really broad look. D, it's okay. It would be okay to start with that, but then you're only focused on a period. Okay. Do you have any questions about growing up? That can mean a lot of things. That could be a really, really wide range of topics that we're looking at. Make sense?
Yeah.
Yeah. Okay. I think if you went with any of those three, you'd probably be fine to set up rapport with the patient, but I think you're going to get the best results. When did you notice that your body was changing? And if they haven't noticed, that gives us a great opportunity to know kind of where they're at. Okay. All right. So now what you're going to do is I want you to take some time and do that ATI assessment, because what that's going to do is it's going to walk you through a reproductive sexual health assessment. So it's pretty good. It doesn't take super long, probably about a half hour. So I'll go ahead and have you guys, you can log off the Zoom meeting if you want to, and then come back at 10:15 after you've done that assignment. That way you guys have had a chance to really look at that so we can move on and talk about the actual sexual history and sexual health part. Does that work?
Yeah.
Yes, you said 10:15?
10:15.
Got it.
Okay.
Yeah.
Okay.
This meeting
perfect.
is being recorded.
Yes, and it is being recorded. Did Zoom say that, or did somebody say that on the microphone?
Zoom.
Zoom said it. Okay, I've never heard it do that before. It's like, that's kind of odd. Okay, perfect. All right, so let's go through and talk about a reproductive sexual health assessment. So when we are starting this conversation, how do we approach this topic? What are some suggestions that you have? How would you start the conversation?
Well, I would first introduce myself and make sure that I'm eye to eye level with the patient.
Yep. I think that's really good. Good introduction. What else? How do you set that foundation to ask those questions?
If they're underage, ask them if they want their parents present or not.
Yeah, that's a good one. Can you see that I'm typing? Is that showing up?
Yes.
Yeah.
Perfect. Okay. All right. What else?
Just asking them if they do feel comfortable with the topic that you're going to discuss.
They have comfort level with the topic we're going to discuss? Do they have, you could even, it depends why they're there, or why are you being seen today? What's going on? What if this was a 65-year-old man who had benign prostatic hyperplasia? How would we start that conversation? Could we tailor this specifically to him with how we're going to start it?
Well, if it was like an older person, you would ask them what brings them in today.
Mm-hmm. Good. What if it's an 8-year-old boy who has something called a hydrocele?
Ask them what is bothering them, like what if it makes them feel uncomfortable, like
I would ask if anything hurts or if they can point to where it hurts.
Yeah. Does anything hurt?
Or
Please.
discomfort.
Or what?
Discomfort.
Discomfort. Sure.
I would ask if they're comfortable, make sure that they're feeling safe in the environment before you really get into the questions.
Yeah. No, Brecklin, you don't need to fill out your own and turn it in. We're just doing it all together. I deleted that assignment off of Canvas. Maybe have them close to a parent. Absolutely. Especially for that 8-year-old. Okay. Go ahead.
Would the parent know maybe a little more than the child? I mean, you would ask the child first, but maybe the parent can help out and fill in the spots.
That's really great. Yeah. For a child, have a parent fill in some of those gaps that the child doesn't know. Yep. What if it was a 20-year-old male with testicular cancer? How are we starting that conversation?
would you ask them how much they know about their diagnosis? Like if they've already been diagnosed, how much they know about it and how much they're wanting to really know about their diagnosis?
Mm-hmm.
Maybe how they feel about like their image. Body
How they feel with
image.
their image, feelings about getting diagnosed, changes that have occurred since the diagnosis. That's a good one. Support person. They came in for the initial visit. When did they first notice the lump? Sure. How about a 16-year-old pregnant teenage girl? She's 12 weeks pregnant. And she's by herself. She didn't bring anybody with her.
Ask her about her support system. Ask her
About her emotions, how she's feeling.
Mm-hmm.
I would ask her what brought her in. Maybe she doesn't even know she's pregnant.
Maybe she doesn't know she's pregnant, right? Or how do you know about what do you know about pregnancy? That's a good one.
Yeah.
Is the partner in the picture? For sure. Okay. And a 49-year-old man with new onset erectile dysfunction. How do we start that conversation?
when did he notice?
When did he notice?
Ask if there's like any psychological factors that have changed.
Psychological factors that have changed. What are you experiencing? Stress. That's good. Any extra stressors? Yep. I think one of the best things we can ask is we can ask this question. Have you noticed any recent changes that are concerning to you? Just to start the conversation. So we've introduced ourselves, kind of gotten a general understanding of what's going on. So have you noticed any recent changes that are concerning to you? Are you on any medications? That's good. Okay, so let's move into number 2 here. History of present illness, right? The things that are happening right now. What are 5 to 10 questions we would want to ask a patient in general who we're doing a GU reproductive sexual health assessment on? What are 5 to 10 things we want to ask? So I agree with the medication, so I'm going to put that in there. Are you on any medications? What else we want to ask?
Are
And
there
any-
input and output? Is it like
Yeah.
burning? Is it a lot, a little bit?
Okay, so input and output. I'm just gonna put details there because there's some details we want to ask about it, right? Yeah. What are your symptoms? That's a good one. Pain or discomfort. Ooh, location, like location of the pain.
Does it worsen when you do certain activities?
Oh, that's a good one. Currently sexually active and sexual partners. What did somebody say up here? Any lesions or discharge? Yeah, that's good. Yeah, pain or discomfort, describe the pain. Aggravating and leading factors. It's good. Maybe when did things begin? How long's it been going on? Does anything make it feel better? Yeah, you guys have asked a lot of good questions. Yeah, feel better or worse. Or one I like to ask, have you done any home remedies is another good one to ask. Have you taken anything for it? That's a good start. Okay. Is it affecting your sex life? How? I agree. Is it affecting your day-to-day functioning? Because that's a big one when people notice interruptions to their daily life. They're usually seeking care, right? Okay, so then we get to the past medical history. I think you guys covered a lot of things in there. I think you covered pretty much everything I have in my notes on the things we would ask them. So past medical history, what do I need to ask them about their past? So I have these things currently. What kind of symptoms are you having? How's this affecting your sex life? Input and output. What exactly are your symptoms? So now I want to know what about their history.
Do they have any chronic illnesses?
Yes. Any chronic illnesses? Yep. Have you had any of these symptoms before? History of STIs? Yeah, that's good. Pregnancy, family history of disease. Yep. Previous STIs or infections. Had any of these symptoms before? Any surgeries?
Is it something recurring? Like if it's something they've had in the past, maybe?
Yeah. For sure. Have you had this before? Recent procedures under the area, that's a good one. Okay, how about personal and social history? When I say personal and social, what do I mean?
like what type of emotional status they're in, maybe? No?
Yeah, kind of. I would want to ask about their emotional well-being. Okay, this is where the partners would come in. Absolutely. Okay. Drinking, tobacco, sexual activity, drugs, alcohol. Yes, I want to know all of that. So this is where we ask the questions about what do you do in your free time? That's really none of my business, but I need to know, right? So drugs, alcohol, tobacco. I need to know about sleep history is a good one. Sleep habits.
Married or single?
What?
Married or single?
Sure. Married, single. Type, don't mind me. Yes, I want to know about sexual preferences. Recent activity. Using protection. I'm just going to put all of that under one thing, and partners. Recent activity. Okay, using protection, partners, oral anal sex, sleep history. It's cancer related, yes, family history. This is also a really good spot to talk about diet and exercise. How's that going to affect sexual functioning? What do you think?
If they're overweight, they probably won't have an active like libido or high libido.
Right. They may not have as high of a libido.
And then if you are hypertensive, you probably have to take medications that like lower your blood flow to the erection.
Yes. They're hypertensive. That can lower their blood flow to the erection, causing erectile dysfunction. Really good.
If you're overweight, doesn't that affect the way you do your personal hygiene? Don't you have to be like more, like sweating and all that?
Mhm.
Take care of it better?
Yep. Yeah. Home and environment. How many people live with them? That's a really good thing to ask. Are they depressed? Sure. These are all good things to add in here. Depression.
Religious preferences?
What'd you say?
Religious preferences?
Yeah. Religious preferences. That'll help us know a lot about that might help us know a lot about their sexual history and sexual functioning too. Sometimes people aren't satisfied. Religion can have a lot to do with that for various reasons, both good and bad. And when we go back to diet and exercise for a little bit too, we talked about obesity and how that can affect, and exercise helps with depression's emotions, makes people feel more desirable, right? Gives you endorphins. Endorphins make you happy, and happy people, according to Legally Blonde, right? They don't kill their husbands. You guys know what I'm talking about? You've seen that movie? Okay. Also with diet, not just hypertension, but diabetes is a big thing. So when we're checking their diet and exercise and getting a picture of their overall health levels, then we're going to find maybe some underlying conditions that could be interrupting their sexual functioning that we need to focus on. So some of those things might be reversible. Okay, so yes, heart problems, blood flow issues. Let's move forward. How do we prepare this patient for physical examination? Is it just how we're going to position them, or is it what we're going to be doing? What do we need to tell them? Lighting, that's a good one.
Explain the procedure, and depending on if they're a male or girl, tell them what position they would be in.
Yep.
Would you
Good.
ask them if they would want to get into a gown, or they prefer not to get into a gown?
We would probably have them get into a gown. I mean, I know like when you're at the OBGYN's office or anything and you're getting any kind of testing done or any kind of exams, they usually need you to be free and open. So we would probably need them in a gown. Let them know what to expect as far as pain and discomfort. Absolutely. Providing privacy. What does this say? Oh, keep them covered, help with modesty. Do they have any questions? Tell them what you're doing. Good lighting. Okay. How do we position a male so we can assess their genitourinary system or their reproductive system?
Standing up,
Yeah, they might be standing. Mm-hmm.
facing the doctor.
Yeah. Also left lying, they can be lying down on their back. So for men, it's a little different how they're gonna do it. Okay, what about a child? Do you know?
On their, assume on their back.
Sometimes, yep. They do something called the frog leg where they kind of sit with their legs pulled up, kind of not quite crisscross applesauce, but like their legs are kind of like this so that you can see everything while they're laying down.
Like
Instead of
squatting?
asking them to prop their legs up.
Like a butterfly.
Yeah, kind of like a butterfly. Not very comfortable for a child when you have to do these types of examinations, right? Not comfortable for the provider who has to do them on a child either. Okay. How about a woman? How do women typically get into positions for this type of exam?
Laying on their back on the table.
Laying on their back on their table with their legs up, right? With the
Yeah.
stirrups. It's called lithotomy. Yep. The lithotomy position. Okay, so yeah, that's good. Standing, laying on the left side. Especially for men, they'll lay on their left side more because if they need to get their prostate checked, do you guys know how to check a prostate? Not that you'll have to do it, but do you know what cavity you go in? Finger in the rectum. Yes, sir. Absolutely. So we definitely want them laying on their side, or some people will stand and like bend over the table. Okay, laying on the left side. They can do a blood test, yes, but there's still tests they need to actually touch the prostate and see if they can feel any nodules in there and see if they can feel it for sizing. They don't use just the blood test alone. They still check the rectum a lot or the prostate a lot. Laying on the left side, lithotomy, frog leg, butterfly. Okay. Okay, so organs will assess on inspection. So let's start with the female genitalia. What kind of organs are we looking at?
The vagina.
Mm-hmm. We're looking at the vagina. Probably not the first thing we're going to look at, but that's going to be part of it. Yep, that external meatus, the labia, clitoris. Mm-hmm.
Are the breasts included in this?
Yes, most of the time. Labia. Mons pubis, good. Amanda prepared you guys so good. The cervix, ovaries. Yeah, as a nurse, I've never used the speculum to check the cervix. Usually if I'm doing it, I pretty much stick to internal or right there, what we can see. If I have to go up, I usually have a provider do that just because of what we're doing and trying to accomplish. Okay, how about on a male?
The scrotum, the shaft,
Just gonna write them as you guys type them in there. Yep, scrotum, shaft, penis, testicles. The veins in the penis. Yep, glands, penis, anus. Essentially the prostate. Also, yes, Brooke, we're also gonna assess for hernias at the inguinal and femoral sites. So just for a refresher, hernias is when there's typically loops of bowel or muscle they're pushing through that opening in the muscle wall and creating little swollen areas that you can palpate. And we don't want those. Those need to be reversed, especially in the inguinal area. Yep, look at the urinary opening, size of the testes. Very good. All right, so normal findings then, what are considered normal? Left testes lower than the right. Yes, that is true. Let's do female first.
Darker coloration than regular skin.
Yep.
Not symmetrical if they've had a vaginal labor.
Right. Colored skin. Usually like a reddish tone. Not symmetrical if had vaginal birth, redness, swelling. Redness and swelling wouldn't be considered normal, but that's what we're looking for.
What about, damn, I lost my track of thought. Hold on.
Can have a scar. Yeah, we're looking at evenly distributed pubic hair.
What about
Like
like clear
sure.
discharge?
What?
Clear discharge? Like
Yeah.
that's one.
Yep. And it's like we kind of talked about earlier, some vaginal discharge or even a little bit of urethral discharge, that's probably going to be a little bit normal depending on the person. So if we find discharge and moisture, that's not necessarily an abnormal finding. What's going to be abnormal is going to be the color, right?
Yeah, or if there's an odor.
Yes, odor. Mm-hmm. Non-odorous. Okay. How about on the male patient? I think we got most everything on the female patient.
Darker skin around the scrotum.
Yep, darker skin around the scrotum. .5 millimeters or bigger if they have hit puberty, I believe. Darker skin and scrotum. Yes. Freely moving, non-tender testes. No lumps or discharge. Smooth penis with pubic hair surrounding. Yeah, no hair on shaft. Hair surrounding the area. Okay.
If
Anything
they're not
else you want to add?
circumcised,
What?
if they're not like if they're not circumcised, make sure it's nice and like clean and odor free.
Right. Not circumcised, should be able to pull. Skin back. Good one, Breeden. No bladder distension. Absolutely. And this could probably even go onto a woman too, able to urinate without difficulty. All right, so findings that are considered abnormal, let's just do whatever, because I think what we would consider abnormal on a woman, we'd pretty much consider abnormal on a man too, despite the differences in the anatomy. Yes.
Foul odor.
Lesions, foul odor.
Bleeding?
Yes, bleeding, absolutely. Redness, swelling, bleeding.
Could
Open
you say
lesion.
like Rita for all of those or no?
The what?
Like Rita for all of those or no?
Yeah, we would use Rita. Purulent discharge or color discharge. What color would you consider abnormal for discharge from a penis or a vagina?
Yellow or green?
Very good, guys. So smart. Okay. I saw someone said pubic lice. Yes, pubic lice for sure. Lesions, foul odor, redness, swelling, bleeding. Crabs, yes. Let's just go with this evidence of STIs. Anything else you'd add in here? Because there's a couple things you're missing. Yep, frequent urination. And changes to urinary habits. Tenderness, that's good. Abdominal pain. And honestly, I'd say pain in general, any kind of pain anywhere. Pain in the reproductive GU system. Hemorrhoids would be abnormal. Extra skin. Finding hernias. Any sort of prolapse, that's a really good one. Does everybody know what prolapse is?
Like when your vagina falls out of its normal placement?
Yep, it could be a vagina. Your rectum can prolapse, your bladder can prolapse. Okay. Yeah, your uterus can prolapse. Anything internal that suddenly comes out that's not supposed to is called prolapse.
Janessa,
Good.
what about unproportional size, like for your testicles?
Oh yeah, so swollen testicles. Yep. Swollen or large testicles.
Hemorrhoids,
Yes, we have hemorrhoids. Only one or no testicles. Yep. No testes. Yes, epispadias, hypospadias for sure. Do you guys know what those are?
No.
urethral opening in the wrong spot on a man.
That's all right. The urethral openings in the wrong spot on the man. So we're actually gonna talk about this when we talk about the when we get to the dysfunctioning lecture here in a little bit, because we're almost done here. Then we would go ahead and look at on the penis. It'll be on the hypospadias will be on the bottom part of the shaft of the penis. So on the penis, instead of your urethral opening being at the end where it's supposed to be, it can be right here close to it. It can be down here. It can be all the way in the scrotal sac, and it can really, really affect a person's ability to have sexual functioning, be able to urinate appropriately, really high risk of infection. And it can make them really, really sick. They have to surgically repair that. And that's usually a congenital defect. So when the babies are born with that, then they have surgery in the first year of their life to fix that. And epispadias can happen to a man or a woman, but it's twice as common in men.
What about like a hermaphrodite?
Ooh, what about it?
Would that be a normal finding or would that be abnormal?
That would be an abnormal finding. Especially when we're talking about someone who's born that way, when they're born with both the male and female sex organs. I'm trying to think of what the correct term is because hermaphrodite's not not the official scientific term. I think they call them intersex. And you probably wouldn't be able to see that at the time. They'd have to do testing. But and Caroline, I'll talk about it in the next lecture a little bit more. But usually when the testicles haven't descended, and if they haven't descended by 3 months of life, they'll start to do testing. And so they know from a pretty young age via ultrasound, CTs, MRIs, if that person doesn't have testicles when there is a place for testicles to be, and they have female sex organs as well. So they do a little hormone testing and stuff. Place. Okay, you guys got a lot of things on here. This is really good. This will be a really good study guide to help you guys study for your test, won't it? Okay, so what if anything needs to be palpated? What do we have to touch, not just look at
Breast,
if we're doing this?
The scrotum,
Testes, scrotum.
the force, like shift back the foreskin.
Yep,
breasts,
the breasts.
female and male, right? Breasts.
Mm-hmm. Yep, bladder and abdomen. Do I need to stick my fingers into a rectum or a vagina?
Not necessarily.
Not necessarily, right? I might wait for the provider on that. Leave it for the provider, yes. Okay. Will we need to collect any specimens when we're doing an assessment like this?
Depending, like if it's a female thinking she has an STI, you might want to do like a swab.
Yeah. I'll say depends on that too. So let's just say depends. But we do want to get some swabs if it's for an STI. We want to check a UA and possibly stool sample. Blood. What do we need blood for? Yeah, HIV, sure. HIV, STI. Yeah, CBC for blood counts. Let's go CMP for your chemistries too. And possibly even to check a PSA, which is a prostate specific antigen. So if we're looking for benign prostatic hyperplasia or prostate cancer or other types of cancers, we might want to do some blood work. Blood for proteins, sure.
Danessa, what's a CMP?
A CMP is a complete metabolic panel. So that's going to be checking your electrolytes and your kidney
Okay.
functions.
Thank
Mhm.
you.
Yep. Yep. We're also going to check the for pregnancy. Yeah, we do pregnancy tests. Semen analysis. That's a good one. Okay. If they have discharge, we want swabs. Sometimes if it's active discharge, they'll actually like milk it to get a sample of the discharge instead of doing a swab. Good. Okay, so let's skip number 11, concerns for this patient, because I was gonna assign you different groups to go over different types of patients with different conditions. So let's just skip that. I think we have a lot of concerns already because we're always concerned about checking for safe sexual practices, prevention of STIs, all those things. We're checking for pregnancy and moral support. So I think we have enough concerns we've discussed repeatedly throughout. Okay, so any risks for sexual assault? What puts a person at risk for sexual abuse? Is maybe a better way to word that. What?
Homeless.
Mhm.
Underage.
Yep. Age for sure. Older or younger. Yep. domestic abuse.
Demented, like if they have dementia.
Mhm. Or dementia. Socioeconomic status is a big one.
What about somebody with like a mental disorder?
Yeah, I'm just gonna, yeah, that's a good one. Mental health disorders. And that could put him at risk for being the abuser too, not just being abused, for sure. Trauma, vulnerability, yeah.
Foster kids.
Foster kids. People who are in comas, for sure. Partner won't leave the room or speaks for the patient. Okay, just being drunk or on drugs. Yeah. Social practices, alcohol, drug use.
If they have a Mexican husband. I'm just kidding.
I'm gonna put vulnerable on here because you guys have said a lot of vulnerable, like breed in that people who are in comas and stuff. Oops, I don't want to do that. Okay. Vulnerable, comas. Even having like chronic illnesses can put them more at risk. Okay, so some of you guys are giving me evidence now. So kids who come in without parents, have another adult who speaks for them, could be human trafficking. Absolutely. That would be evidence. Okay. Females are typically more at risk for sexual assault or sexual abuse than males. But I think probably as far as like being abused as a child when you're sexually abused, it's probably about 50-50 males or females who are being abused. And a woman who's a prostitute, she could be more at risk for sexual assault or abuse. Yeah. Okay, so evidence. Yeah, no eye contact. Males don't speak out as often about it. That's absolutely true. Yep. Young children with STIs or trauma. Bruising, flinching. Kids who come in without parents or have another adult speak for them. Partner who won't leave their side. Oh, you guys have lots of images here. Child being pregnant without knowing, paranoid behavior, inconsistent story or trauma, reluctancy, dismissive or avoidant, close body language. Yeah, those are really good. A lot of evidence there. Abnormal sexual behavior, sure. A lot of kids who are sexually abused act out sexually as well. They have knowledge they shouldn't have about explicit sexual acts. Denial.
Like what they talk about also with that,
Yeah.
like the vocabulary they use.
Mm-hmm. I'm gonna say inappropriate vocabulary and knowledge for children.
What about like seeking special attention from certain individuals?
Yeah. Um, irritability from an older adult, absolutely. And I think another one we can do too is fear. A lot of times they have irrational fear of certain genders, or I really hate to say this, it didn't happen in Mead, but there was an older lady being sexually abused in a nursing home, and she was terrified of men and women that had a certain color of hair because she couldn't distinguish her attacker from anybody else with that same color hair because of her cognitive abilities. She didn't realize what had happened, but she had this irrational fear of people with a certain color hair. So, what else was I gonna say? When you have victims of human trafficking or sexual abuse that come through your ERs, your clinics, typically you can tell when something's wrong and something's going on. Why do I say that? Behavior. Yep, it comes down to their behavior. Not so much in the children, but children sometimes have a way of describing things that don't always make sense to us. I heard this story about this child who kept talking about how her uncle kept touching her cookies and no one knew what she was talking about. Turns out she'd been taught that cookies was the word for her private parts on her body. She's just real small. And so no one caught on to the fact that she was being sexually abused. Is an instinct that you develop more as you work. Body language is a huge part of it. The things kids say, I've personally done with police supervision. I've done sexual assault and sexual abuse checks on children who were being removed from a home, and we had to photo document and check for evidence of neglect and sexual abuse. And it's really hard to see. But older adults too, they're also sexually abused, or people who do have less cognition or less ability to understand. So I think you do learn to know what's happening, especially if something is said. As a nurse, sometimes those instincts are a little bit better than when it would be something happening in your own family, because in your own family there's usually a lot going on. We don't always catch on to things, but when you're in the hospital and you have patients, you don't know those patients, so things don't make sense. Yeah, Braden's right. A lot of times abuse is reported a long time after the incident, and sometimes evidence is not present. Absolutely. A lot there. So just some things to know, because when we're doing these checks, we might run across something we're not expecting. So you might have parents like, oh, don't you dare touch my child like that, I won't have it. They might be trying to cover something, okay? Because it shouldn't upset a parent. If you have a legitimate reason for needing to do this type of assessment, they should not get upset about you needing to do your job. So just some things to think about as we move forward in our careers and we're doing all of this. Okay. I would say, what do you need to ask a patient about sexual history, or do you feel like we've covered that already? SANE exams can be very traumatic to patients. Yes, when they are sexually assaulted and they're doing exam on them, it's very, very traumatic. So what do you guys think? Have we covered enough about sexual history? Do you feel like we can move on to our next thing? Or do we want to list some questions on here that we're going to ask? Yes, covered.
I think we covered her.
Okay, I think so too. I think you guys did a good job. So you guys did a really good job setting that up. So now you kind of have a good foundation of I will, yes, I will post this for you guys on Canvas when we're done here. So I do think you guys now have a good foundation. You guys did all the work here. So kind of figuring out what that's gonna look like on doing a repo and sexual health exam. So I'll post this for you guys. I think it'll really help you just studying for your exams to just kind of figure out what else, if there's any gaps you have that you need to know. Okay, so let's take a short break. Okay, it's 11:03. At 11:10, we'll start our sexual dysfunction and work through that really quick, and we should be done before too long. Okay?
Hey, Chanessa, quick question.
Yes, ma'am.
Not regarding this, but regarding the sim on Friday, will you have more information for us?
I will post more information for you. Yes.
Okay, thank you.
Thank you. Increased infections, trouble urinating. Yep. Infection. Yep. All right. Moving it on. All right, structural defects. They're gonna have something called phimosis. This happens, it can be actually normal in uncircumcised infants and young adults, but this happens when the foreskin of the glans penis can't be retracted. So it's like grown over the outside and it's really, really tight. So when you try to pull it back, you can't. So what do you think would be your risks for this if they are uncircumcised and they get phimosis?
And erectile dysfunction.
Erectile dysfunction could happen, sure.
Infection.
Infection, big one. Decreased blood flow, yep. And it actually increases their risk for penile cancer if they have phimosis. So infection, proper hygiene, which can cause a lot of issues on its own, decreased blood flow, okay? How do you think we fix this?
Circumcising.
Circumcising, yep. Good.
Education.
Education as well. Yep, making sure they know to pull it back frequently so that it doesn't close over. Keep it clean. Cryptorchidism, I can never say that right, okay? This occurs when one or both testes fail to descend into the scrotum, and it's found on initial newborn exam. Typically, in gestation in the 7th to 9th month, that's when for boys, their testicles will drop into the scrotum. When they fail to do so, we end up with cryptorchidism. So this can actually cause infertility in males if they have this, and it can also significantly increase their risk for malignancy. So testicular cancer and other types of cancers of the reproductive system. Often if they have this, they have because they come through the inguinal canal, they have inguinal hernias. I'm gonna write that in there for you. In a majority of cases, though, when babies are born and their testicles have not descended by 3 months of age, they should have spontaneously done so. Okay. If they don't by the 3 months, what do you think they do? What are we gonna do?
Orchiopexy.
We might do an orchiopexy. Very good. An orchiopexy is surgery to bring the testicles down where they belong. Okay. Before we do an orchiopexy, we want to do some testing. So we're gonna find where in the body those testicles are with ultrasound, CT, MRI, etc. And then see, is it because they're stuck somewhere? Is the path just not open? Is something tangled or tied off? Is there something wrong? Do they not have any testicles to come down? And so then they can do some more testing like hormones and chromosomes. Is it an intersex disorder? Is it something else altogether? Make sense? So then they do the orchiopexy, and typically when they do that, they untangle a lot of blood vessels so that the testicles can come into the scrotum, okay? If the testicles are defective when they get there, they'll take them out to prevent the risk of later cancers, and they'll put a prosthesis in so that it looks like there's a testicle in there but there's not actually a functioning testicle in there. So what we want to see happen here is that the hernia is repaired if there is one. We want to improve their chances of fertility because one testicle doesn't change a chance of fertility. So you can still be very fertile with only one testicle. We want to prevent testicular torsion. We don't want things to get tangled up and twisted off and cut off that blood supply. And we also want to prevent the risk of cancer in the future because, like I said, cryptorchidism has a huge, huge, huge risk of cancer. So make sure you know that because you'll need to know that for your exam. Okay, and then inguinal hernias and hydroceles. We're just gonna go over this really quick. Okay. Inguinal hernia is a painless inguinal or scrotal swelling, usually when loops of bowel extend into the inguinal canal and need to be surgically removed out. Okay, a hydrocele is painless swelling of fluid in the scrotum that usually reabsorbs on its own by 1 year of age, but it can also occur spontaneously in adults. Could you lose the ability to get an erection with a hydro, with which one? Which one are you talking about? If you could lose the ability to get an erection. Cryptorchidism. I don't know that it affects the ability to get an erection because the blood flow is going to the penis to get the erection. That just has more to do with the function of the testicles. So you might lose your ability to have orgasm, but maybe not the actual functioning of the erection. Good question. That's why they fix it. Oops, sorry guys, didn't mean to do that. Hydrocele, I saw this one time in practice. It was this trucker he stopped through in our ER because his scrotum was literally, is my camera still on? It is, isn't it? Yeah.
Yeah.
They were literally swollen, like almost as big as my head. That's how swollen he was. And it happened from an infection that he got because he was peeing into bottles he had in his truck. He was using sweet tea bottles, so he didn't have to stop all the time. And so all that sugar from that rim, tons of bacteria grew on there because he kept reusing the same bottles, just pouring them out and peeing in them again, and led to him getting this massive infection in his testicles. So they also called that a hydrocele because his hurt, it wasn't painless, but it happened spontaneously, and they call it a hydrocele when there is swelling in the scrotum. In clinicals at the hospitals, there was a male that had that. Yeah, it's insane. Yeah, I don't even know what else to say about it. So any questions about these things that we've talked about right here?
No.
Okay, perfect. All right. Could that happen from a dirty urinal? It shouldn't, because the urinal has a really big opening on the top. Like if you're talking about the hospital urinals, they're about as big on the opening as the top of my cup. But when you're peeing into bottles like that, the openings are a lot smaller and it can rub on there. And that's what caused the infection, was that it was rubbing against his balls and his penis. So. Okay. Testicular torsion. This is an emergency condition. Okay. This occurs when the testicle twists. You can see that photo here. Sorry. It's all twisted up and it's starting to turn purple. That's because that blood supply is cut off. And when the blood supply is cut off, the oxygen's cut off. And so then things start to die. So that's what's causing the pain, is when that blood supply and that oxygen supply is cut off to the testicle. We get severe pain. Externally, they can have redness. They can get nausea, vomiting, abdominal pain, and their scrotum will start to swell externally. We are going to have to do an orchiopexy to remove that testicle and untwist it. So sometimes they can save them. Sometimes they have to remove them and put in a prosthesis if they get that. Okay. But our ultimate goal is to save the testicle. When this happens, oftentimes our male patients can have some psychological support that they need. Okay. Because only one testicle is involved in this, typically fertility should not be affected. I actually know several people who've had testicular torsion and had one testicle removed, and they all have kids without issue. So that's great if that's what they want. Okay. Proper care of incision and pain management, no heavy lifting for 4 weeks, no strenuous activity for 2 weeks. And then you want to teach men to do testicular self-examination. Anybody care to comment on testicular self-examination? What is it? What happens with it? Why do we do it?
It is done to check for any cancers within the sac or beside the testicles of the male.
Right. Check for cancers, check for lumps, check for abnormalities. Right. Because we know that if we were to do a testicular exam during our assessment, they should be pain-free when we touch them, right? Free and movable. Okay. No issues. Yeah, Breeden's right. Torsions and epididymitis and any kind of swelling can be found when we do testicular self-examinations. Okay. Really good thing to do once a month, the same way women do breast self-exams once a month to check for lumps and bumps. Okay, that aren't supposed to be there, because the best way to get ahead of something like this is to prevent by doing that. So really good thing. Check for abnormalities. Should be pain-free. If you experience pain, find a lump, great time to go in and see your PCP. Okay, so this is just a review of the anatomy of the male reproductive system. You see the star there on the prostate. That's where we're going to head first, is to talk about benign prostatic hyperplasia. All right, so benign prostatic hyperplasia. What do you guys know about this? Have you heard of this before? You don't need to know all the anatomy for the test. No, you're not doing
Is that
any
like
lifting
an
for the
enlarged
test.
prostate?
It's an enlarged prostate. Absolutely. Yep. It's an enlarged prostate. When this happens to men, they experience some symptoms that usually start really slow. They don't always realize that there's a problem until they're very noticeable and obstructive. Okay. So we talked about the difficulty starting and stopping the stream. They usually have a really weak stream with this. They'll have to get up at night and pee. They didn't have to do that before. They'll have more urgency, like they need to go right now. They'll have some pain in their bladder, some incontinence. Those are usually the first things they notice. Then as it gets worse, then it begins to decrease the force of the stream. So now they have less urine trying to get through. Sorry, that didn't come out right. Because that prostate starts to grow, the way it's described is that the bladder is pushing the same amount of urine a lot harder to get through a much smaller hole. And so that's what makes it hard to start and stop that stream. That's what makes that urine flow weak and decreased. That's what makes it hard to continue that stream. It's always stopping and starting and stopping and starting. And that's what's causing some of the dribbling. So questions about this. They say that it does not lead to an increased risk for prostate cancer, but it does need to be watched and managed. We did talk about prostate cancer last semester when we did that simulation for Frederick Clark. Okay. There are some complications that can come with this. What do you think are complications of having benign prostatic hyperplasia? What are some concerns we have that we're watching our patients for? UTIs, good one. Incontinence, great one.
Retention?
Urinary retention. Blockage, good. Okay. If it gets too bad and the urine just cannot get out, eventually it'll start to affect the kidneys and make them shut down too. So then we're looking at risk for renal failure. Okay. How do we think we diagnose this? How does this come about?
I've had it to where they find out when they're trying to put in a Foley and they can't.
They can't put in a Foley, right? They didn't know they were having trouble with their urine and they can't put in that Foley because it's too big. Okay. Finger test, yes. So they'll do a digital rectal exam to feel the size of the prostate, see if it's in the way. Okay. They'll also check a PSA, a prostate specific antigen, through the blood, because this might be slightly increased in patients with BPH. So yes, Brooke, the PSA does elevate, but slightly, not significantly to where they're worried about cancer. Okay. If both the PSA and the digital rectal exam are abnormal, then they'll do a transrectal ultrasound to also figure out the size of the prostate and is this BPH or prostate cancer. There is not an antibiotic that they can give for it, no. Antibiotics don't help because it's not an infection, but it could be enlarged, or they could be having some of these symptoms because of an infection. So if they give an antibiotic and that helps clear up some of those symptoms, then it's probably not the BPH. That's a really good question, Brian. Thank you. Okay. NSAIDs would not help with swelling in this case, but it might help with some of the pain. So treatment for this is actually in the pharm lecture, so I'm not going to go over it again, but there was some medications. One of them was called Flomax to help improve that stream of urine. Nothing's necessarily going to reduce the size of the prostate. So ultimately they'll have to have what they call a TURP. Okay. All right. So let's talk about care planning. Okay. So we talked about complications, problems, or potential problems. Okay. What kind of interventions are we doing for someone that has BPH? Besides giving them medicine, what are some things we're going to do as nurses? Education. Yes. About what?
What they can do to feel more comfortable and be in less pain.
Sure. So what can they do to be more comfortable and be in less pain?
Peeing frequently.
Peeing frequently. Sure. Catheter for bladder distension. That's a good one. Okay. Have we talked about the Coude catheter before?
I think we saw it, but I don't think we really talked about it.
Okay. So a Coude catheter. So you guys know what the Foley catheter looks like? Yeah. It's the one with the harder tip on it. And it's kind of bent a little bit at the tip so that it goes past that enlarged prostate and into the bladder. So that's one thing that they can do is we might need to use a Coude. Sorry, my pen changed the page. The Coude catheter. Okay. They might have to self-catheterize intermittently. So you'll have patients that have BPH. They'll actually insert their own catheter every 6, 8, 12 hours because they cannot pee anymore. They have problems with really bad urinary retention from this, and that bladder has to empty or they have bigger risks for problems. So self-catheterize is one that they'll do. Okay. Should they drink less so they don't have to pee so much?
No.
No, they should not. They should have really good fluid hydration.
Yeah, because they'll dehydrate.
Yeah, if they get dehydrated, that's worse. Okay. What else? Stay away from sugary drinks. Sure. Sugar, alcohol, caffeine, all of those things can really worsen a person's normal or abilities for urination. So we might want to have them avoid caffeine, alcohol, sugary drinks. Sugar drinks. Okay. Diet's important. Good. Why do you think diet, Carolina?
Because of the sugar in like junk food and fruits and vegetables and all that affects urinary patterns.
Yep, it does. Good.
What about
Okay.
like salt? Like, would they have to avoid the salt to avoid from like retaining fluid, like swelling?
That's a good one too. Yeah, avoiding salt. I'm just gonna put diet, sugar and salt. Good thought, good thought. All right, so how does this disorder affect sexual functioning and sexual expression?
They may not enjoy the sexual activity.
They might not enjoy. Do you think maybe they're embarrassed if they're having dribbling or difficulty urinating? They maybe don't have sensation either. Would it affect ejaculation? I don't know if it affects ejaculation because that part of the anatomy is not necessarily going to be having problems. I'm trying to think through the way the anatomy works. It shouldn't affect ejaculation, but it might, because that prostate could get in there and interfere. I'm not actually for sure. It's a really good question. Prostate hormone changes might cause some erectile dysfunction. Sure. Typically BPH is also caused by the loss of testosterone, and that leads to other hormones in the body increasing, which are making the prostate grow. So that could affect sexual expression too if the testosterone is decreased. Less testosterone. Put some embarrassment here. Yeah, social and emotional. If you've ever had any issues with incontinence or anything like that, even post-pregnancy, you know that can be embarrassing, and you know it can also be kind of smelly sometimes. So you have the odors that you're looking at. Okay. Some risk factors we're looking at: aging. Okay, just normal part of aging is that the prostate can grow, obesity, lack of physical activity, high diet of animal protein, a lot of alcohol use, smoking, diabetes, all that can affect. Okay, so that'll probably affect sexual expression more if they have underlying conditions as well. Expected education needs based on what we talked about. What do we need to educate about? Can this disease be prevented? Yes, Breeden, it can be genetic. Carolina, yes. Don't hold in your urine. Go when you have to. Very good. Regular checkups. That's good, Brooke. Checking those PSAs. Drink lots of water. And if they do have this, then we're probably going to educate them about how to self-catheterize, how to keep that bladder empty, how to improve sexual functioning, right? Or maybe give them some alternative options they could do. Good. All right, so now we're looking at a transurethral resection of the prostate, or a TURP. So when the prostate gets large enough, they need to cut it away. So what they're actually going to do is stick a little scope into the hole in the urethra, and it's going to go in and it'll actually cut away and cauterize and burn away the extra part of the prostate that's too big, that's blocking off the urethra. And so then after that, they'll put in a 3-way Foley. So when you think of a 3-way Foley, it looks a lot like a regular Foley catheter, except the Foley catheter tube is pretty much a straight tube over here. And then you have your little tube over there. Okay, this one has, sorry, I can't draw with my pen very well. Tube like this. And then it has three-way splits on it. And so what they do with that is that this part will go into the penis, and then they'll have something called CBI, which is continuous bladder irrigation. And it's this big bag of saline. It's probably got 5,000 mLs in it, and they'll hang it and they'll let it flow into the bladder, and then it's coming out with blood clots, urine, etc., into a Foley bag that's hanging over here. So you have your bag of continuous infusion going in one tube, this one going into the other, and then you have your spare for samples, irrigation, etc., if things are happening. So complications of this, you can have a lot of bleeding, clot retentions, can be very painful. Okay. Once we get this fixed, we should be finding that they have more satisfying sexual expression and complete bladder emptying and restoration of urinary control. Okay. The CBI is not run on an IV pump. It's actually just has a little clamp on it. And so when you're adjusting it, you'll adjust it according to the color of the outflow. So the CBI will be your inflow, and then the Foley bag will be your outflow. I'm going to talk about that on the next slide. So with this, okay, we want to prevent complications. So we want to prevent that hemorrhage after surgery. We want to prevent bladder spasms, urinary incontinence, and infection. So when they get that bladder irrigation, we want the urine to be pink without clots. So when it's going into that Foley, okay, one's going to be your inflow, so that's going to be your bladder irrigation. One's going to be your outflow. Okay, don't worry about which tube's which. Your outflow should be light pink, no clots, and coming at a pretty regular rate. Okay, your inflow will be totally clear. If your outflow starts to get dark again, so we refer to these typically in drink colors. So Hawaiian Punch is a go-to. If it looks like Hawaiian Punch, you need to turn your bladder irrigation a little bit faster on the clamp. I was going to show you all this in class today. So if I think about it, I'll set it up in the skills lab. You guys can run by and look at it, or we can do something with this for one of your simulations too, because we have some time to plan that. This is a really common thing that you'll see in the hospital. This is one of the most common surgeries I did post-op. And so then you have to monitor when that bag is empty, you have to hang a new bag of your saline, and you have to empty your Foley bag. I mean, usually every 15 to 30 minutes, you'd be in the room either emptying the Foley or hanging a new bag of fluid, and you have to keep track of all of that on your INO. We want to post-operatively, we want to avoid activities that increase abdominal strain. So things like walking, sitting, straining for a BM. Okay. We want to monitor for bladder spasms. So if they're bladder spasming, they're getting really bad pain in their bladder. And we're going to check for clots. We're going to check and see something's kinked off. It's not flowing out properly. And then maybe we'll manually irrigate if necessary. So we'll get a syringe and see if we can pull that clot out, something that's kinked up in there. Okay. Bladder training. When they get ready to take that Foley out, usually about 24 to 48 hours after surgery, we want to make sure they know that sometimes full continence takes several weeks to restore. So they don't just get their continence back, they have to work at it. Sometimes it's never quite the same and doesn't fully resume, but we do want to teach them about continence training. Monitor for signs and symptoms of infection. Okay, you know what those are: redness, drainage, swelling. Okay. Before they go home, we want to teach them to care for their catheter, make sure that they're emptying those bags properly, because they won't have that inflow anymore. They'll just have the outflow. Make sure they don't get clots in it. Preventing constipation. How do we do that? We don't want them to strain when they're going to the bathroom. What can we do?
Colace?
Colace. Give them a stool softener and drink lots of water. Yes, very good. High fiber in their diet. Okay. Avoid lifting more than 10 pounds for several weeks after surgery, and then they should refrain from sexual intercourse until they're directed by their doctor. It's at least 6 to 8 weeks or more with this surgery. Okay. Okay, problems of erectile mechanism. So we have two. There's priapism and Peyronie's disease. So priapism is when they have painful erection lasting longer than 4 hours. This is usually some type of obstruction so that the blood can't flow out from the penis, and that's why it can't get flaccid. Complications, it can actually lead to penile tissue necrosis and kill some of those cells in there. And there's a risk for permanent erectile dysfunction. So we really don't want to do that. How do we treat someone that has priapism? What do they do with it? Anybody know?
Vasodilators?
Yep, they might give them some vasodilators. Okay. Help with that. See if they can get that out. What else? If that doesn't work, what do they do? Ice, sure.
They
Drain the
inject
blood
it?
from the area. Yep. What did you gonna say, Brian?
I was just gonna say they inject you with something.
Yep, they can inject you with something, and if worse comes to worse and they can't get it to go away, they'll actually take a needle and syringe and drain the blood from the area. So very painful. The next one to talk about is Peyronie's disease. There's a little YouTube video. I won't show it to you now. It's a commercial for medication they use to treat it. So you treat it with something called Xiaflex. You don't need to know that for your test. But the commercial has a carrot and it asks, is your carrot bent? So basically Peyronie's disease, in this disease, it's not dangerous, but it can cause painful erections, erectile dysfunction, and embarrassment. And it causes the penis to be really bent during erection. And so that happens when there is plaque buildup in there from nodes or trauma or something going on, some kind of underlying disease flow that prevents adequate blood flow. So it gets curved and it can be very embarrassing. So treatment, Xiaflex, which is the medicine on the commercial there. Uh-oh. Okay. Next page, please. Thank you. Okay. Erectile dysfunction. This is a big one that we have to talk about. It's one of our main ones. Okay. Inability to maintain or attain an erection that allows for satisfactory sexual activity due to inadequate penile blood flow. Okay. 50% of men between 40 and 70 have some degree of this, and it goes up as they get older. There are a lot of causes. Your most common ones are going to be diabetes, some type of vascular disease, side effects from meds, stress, trauma, and depression. This is a big issue because it's so prevalent and so many healthcare providers are uncomfortable talking about it. Due to age-related changes that can cause this naturally, it is necessary to talk to older men about normal changes in their sexual abilities and how to prevent potential problems. A man's inability to perform sexually can cause a lot of distress in his interpersonal relationships and may interfere with self-concept. So when we're diagnosing and screening and assessing, we have this little questionnaire we give them. So it's 5 questions and they can score their points based on this. Okay. So we want to start with a screening tool. So if they ever say that this isn't working or it's very low, we would want to for sure do some further assessment. So how would you rate your confidence in keeping an erection? When you had erections with sexual stimulation, were they hard enough for penetration? During intercourse, were able to maintain your erection? So it's just kind of asking about some different parts of that sexual plateau, that sexual cycle, and some different diseases. So it could be looking at premature ejaculation, inability to orgasm, not just erectile dysfunction. But either way, this little questionnaire really helps us get a good kicking off point for what we want to do. So once we have this finished, our next step is going to be to assess secondary sex characteristics. Where are they at in the Tanner stages? Are they able to give us any information about their sexual health history? We're going to do a digital rectal exam. We're going to do a PSA and do some checking for diabetes and blood pressure and hormone levels. And then we'll actually do some penile tests to assess the degree of dysfunction, because we want to know how bad is this, how much treatment is this going to need. So treatment, okay, the goal is to have satisfactory sexual relationship with the patient. First thing we want to do is determine if it's reversible. So is it caused by side effects of medication? That might tell us that we can explore some other treatment options. So a lot of heart medications can cause ED, okay? Antidepressants can cause ED. So we might need to explore some other treatment options. They might need some androgens or testosterone or other types of hormone replacement to help with that. That's an easy fix, okay? Is it psychological in nature? Is it because of a poor relationship? That can be fixed with therapy, okay? Emotional support, making sure they have confidentiality and helpful information. That can help reverse the problem. We're gonna give them medications, okay? They're called PD5 inhibitors or phosphodiesterase 5 inhibitors. We talk about these in your pharm class, okay? It's going to be your Viagra, your Cialis, things like that. There's something called a vacuum erection device that they can use. It's a little suction device that's placed around a flaccid penis to draw the blood into there to stimulate an erection. And then you stick a band around the base of the penis to keep that blood flow in there and keep the erection long enough for sexual functioning. I don't know if this affects the ability to ejaculate or not. I'm not sure if it affects orgasm. I just know that it helps to stimulate that erection as needed. And if that erection can be stimulated, then the assumption is that everything else is still functioning as well, if it's a blood flow problem that's causing the problem with the erection. There are some devices and injections we can do for our patients. So they can have some vasoactive drugs in a gel or a pellet that they insert into the head of the urethra. And that will stimulate blood flow, causing an erection. So that's a really easy fix as well. There are penile implants that they can get if they have really bad ED. So with the penile implant, they get a series of little blow up cylinders. They just kind of look like little, like this, that are placed throughout the penis, and then they get a pump installed into their scrotum. And so when they're ready to have an erection, they'll just squeeze their scrotum and pump it up, and then have sex, go through all of that, and then the release pumps in the other part of the scrotum, so then they'll just release the air out of there. So there is that option as well. And then, of course, sexual counseling, which can be recommended at any point during treatment for erectile dysfunction. We want to address any psychological or interpersonal factors. And it's usually done with patient and their partner together if they're in a long-term committed relationship, so that they can figure out the problems together. So we have cancers of the reproductive system. So prostate, pedile, and testicular. I'm not going to go in major depth with each of these. Okay, there's a couple of things I do want to go over. So we're not going to do the activity necessarily, but I want us to talk about this a little bit. So based on what you know, okay, what causes prostate cancer, what causes penile cancer, and what causes testicular cancer? So there are some differences. What are some risk factors? Has it diagnosed? Is there any type of prevention? Okay, and age of onset. So like with penile cancer, most often this one's caused by HPV, which is human papillomavirus, which I don't know if you know this, can be prevented by a vaccine. Okay, it's not the only thing that causes penile cancer, but it's one of the main ones. You can get HPV vaccine so that you don't get this. It's a sexually transmitted disease. So that's kind of what we're looking at. Let me open my book really quick and flip to that page. I didn't post a whole lot of information on here because we were going to do this in class today, not have a snow day. So my apologies, guys. So talk to me. What do you know about the differences between these three cancers?
Could their lifestyle put them more at risk?
Yes, how so?
Like if they like, well, like could it be genetic maybe?
Okay.
Their race?
Race, sure.
Would multiple sexual partners or multiple STI infections increase the risk?
Yeah, especially for things like penile cancer. Excuse me. What'd you
Does
say?
smoking affect it? Smoking?
Smoking, yep, smoking can affect it. Reading says testicular cancer, one of the most curable. Yes, it is the most curable.
What about like if they have like diabetes and stuff?
What about it? What do you think?
Does it make them more susceptible to it?
Not to developing cancer. Nope, not necessarily. But yeah,
Okay.
genetics is a huge part of testicular and prostate cancer. The cause of prostate cancer is usually hormonal. Changes in the hormones.
Hormonal.
Yep. Testicular cancer is higher in people who have the cryptorchidism, the undescended testicles, or HIV. Actually, I didn't know that, but that is kind of interesting that it can be caused by the cryptorchidism and HIV. Okay.
And is it more common in young?
It's more common in young men. It's most common in like 20 to 35-year-olds for testicular cancer. Penile cancer is also more common in young men because of the risks of getting it with the HPV. Okay. Prostate cancer is more common in older men. Penile cancer more common in uncircumcised. Yep, absolutely. Page is gonna be a mess, isn't it? Okay, signs and symptoms. When you get to prostate cancer, there's not a whole lot of them. So it's usually hard to figure out that there is cancer. Frequent urination, okay. We're also gonna see hematuria, so blood in the urine, which will be a big change. Yep, blood or semen in the urine, okay. With penile cancer, yep, you see sores on the skin, very good. Testicular cancer, again, you have those lumps inside the testicles. Prostate cancer also has frequent urination. Urinary retention, frequent bladder infections, pain during intercourse, especially when ejaculating, can be a sign of prostate cancer. Treatment, how do you treat these?
Would chemotherapy work?
Yep, chemo, radiation, removal. Okay, we're gonna do radical prostatectomy here. Get that out. With the penile cancers, we want to treat the HPV and probably going to remove the cancerous sores as well. It's chemo and radiation. Testicular cancer, remove the testicles. Yep.
When you said like a fake testicle, is that just for appearance?
Yep. They'll give them like a prosthetic.
A prosthetic, okay. What is this?
That's cryptocortism, the undescended testicles. Okay, prevention of prostate cancer, screening, PSAs. This one we talked about with the prostate cancer in that simulation we did. We talked about the active waiting or the watchful waiting. So there's a lot of stages of prostate cancer. They do a lot of PSAs and just see how it's growing because it's a very slow growing and not very progressive. So there's usually a lot of time involved with this before they have to do anything. Testicular cancer. I don't know that many people that have had testicular cancer. It's got a fairly high survival rate, like Breeden said. I do know a young guy that had testicular cancer, didn't know, he got into a car accident. That's when they found it, and he died in 2 years. So I think it's just gonna be different in everybody when they find it too. Okay.
So it does metastasize, Janessa?
Testicular cancer?
Mm-hmm.
Yes.
Yeah.
It can.
Oh.
Mm-hmm. Okay. Any questions about anything we've talked about today? Do you feel like there's enough information covered? I know it's not quite conventional because we had to go online. So I really appreciate everyone's involvement. You guys were really active and engaged. So thank you for that. Since it's recorded, I think all of your chat stuff will record. I'll make sure I post those review questions. I'll post that sexual health assessment we made. Okay. Anything else I can do for you to help you guys? Do you get ready for your test?
I don't know if I misunderstood you yesterday, but were you gonna upload a YouTube video?
Yes. Yep.
Okay.
I'll do one of this, what we talked about today. And then I'll also do one about the sexual development across the lifespan. And that one is more some background information on how that occurs, going through some of those stages of puberty and just sexual development from children to older adults and sexual behaviors, so that you have a good understanding of why we're assessing the way we're assessing.
Okay, and that's the one we have to watch before the test, right?
Yes.
Okay.
And it won't be very long at all. What do I
Okay.
recommend looking over and focusing on when studying for the exam? Do we focus on all 4 PowerPoints provided? I would look at the student learning objectives and kind of start there, see where you understand well and what you need to look up more before you go back through all the PowerPoints, because the PowerPoints are not very lengthy. And so just to clarify, turn in the ATI. Yes, you don't need to turn in anything else. Just turn in the ATI that you did that. There is one assignment on there. It's due February 4th. So that gives you a couple of weeks to do it. And it is a sexual health history. You have to take 2 sexual health histories. You can use a classmate, a family member, whatever. But I would like you to, if you do one on a classmate, do one on somebody who's not a classmate, so you can have a conversation with someone you're not quite as comfortable with. And then you have to do a short reflection over that sexual health history and then put it into paragraph forms for both of them. So it's not a very long assignment. It won't take you super long, but I do want you to do that. Okay. Yes, Brooke, either one's fine. They were both pretty much the same, I think, when I looked at them. Okay, any other questions?
No.
Okay, I'll be in my office tomorrow again. Hopefully the roads will be better. So if you guys need something, just stop by. I know you guys start clinicals tomorrow, so you'll do
And
great.
you'll let us know for Sims, right? For lab, whoever's having Sims on Friday.
Yes, I'll let you know for Sims for lab.
Do we plan on meeting at the Allied Center or?
Yeah,
do
well,
we
it'll
plan?
be at the in our simulation building.
Okay, Okay, just at 8:30?
Yeah.
Okay, thank you.
All right, you guys are officially dismissed. Thank you very much.
Bye.
Bye.
Have a nice day. Thank you.
Yes, you as well.